Very good morning to all of you. Welcome to the 22nd Annual Scientific Congress of the Perinatal Society of Sri Lanka. So today morning we are going to start two parallel symposium. One symposium in this hall, Managing Past Caesarean Section to Optimize Perinatal Outcomes. I warmly invite the two chairpersons, Professor Rukshan Fernando Pulle, Professor in Obstetrics and Gynecology, Faculty of Medical Sciences, University of Sri Jayawardhanapura, and President of Board of Study in Obstetrics and Gynecology, and also Dr. Mangala Disanayaka, Consultant Obstetrician and Gynecologist, President-elect Sri Lanka College of Obstetricians and Gynecologists, and past President of the Menopausal Society, to come on to the stage and start the sessions. Thank you.
Good morning to all of you, and thank you for the kind introduction of us. So to begin this session on managing past Caesarean sections to optimize perinatal outcomes, may I invite the presentation from Dr. Chamila Avvayu from India on immediate and late complications of Caesarean section. Dr. Chamila Ayavo is a consultant obstetrician and gynecologist and director of Aditya Hospital and Paravati Ayavo Family Fertility Center in Trichy, India. She is the Vice President-elect for the Federation of Obstetricians and Gynecologists Societies of India, FOGSI, in 2024. She is a very active member of many societies, including the chairpersons of the Clinical Research Committee, National Coordinator of UNICEF, and WHO projects of FOGSI. So over to Dr. Chamila for the presentation.
Good morning to all. My talk today will be on short and long-term effects of Caesarean section on the health of women. I am Dr. Charmila and I'm from India. I'm the Vice President-elect of FOGSI 2024 and I've been the chairperson of the Clinical Research Committee of FOGSI in 2016 to 2018. I want to talk about Caesarean section. You have to remember what the WHO said in 2021. They've said that Caesarean section rate has risen globally and it now accounts for more than 1 in 5 of all childbirths, and that is almost like 21% of all childbirths. With the increasing rates, nearly a third, that is 29% of all births, are likely to take place by Caesarean section by 2030. And you can see the burden for the future because of the increasing Caesarean rate nowadays. And WHO 2021 and American College in 2023, they have said Caesarean sections can be essential in prolonged or obstructed labor, may be needed in fetal distress or malpresentations. But we have to remember that as with all surgeries, they can have their own risks. Then there's also no evidence of concomitant decrease in maternal or neonatal morbidity or mortality just because the Caesarean section rates have become higher. And that's why it has raised a significant concern that Caesarean delivery is quite overused. The risk with Caesarean delivery can be in the form of heavy bleeding or infection. There may be a slower recovery time after childbirth. There may be delay in establishing breastfeeding and skin-to-skin contact between the mother and the baby. Then there's always an increased likelihood of complications in future pregnancies. Regarding the short-term risk because of this procedure, they can be in the form of intraoperative complications. There can be a risk for activating massive transfusion protocols. There may be an increased chance of infections and hematomas compared to a vaginal delivery. There may be an increased risk of venous thromboembolism. There is a higher incidence of amniotic fluid embolism following a Caesarean delivery compared to a vaginal delivery. And there are also neonatal risks which are attributed to a Caesarean section. There may be severe maternal morbidity, and sometimes there can even be mortality of the mother because of a Caesarean delivery. Regarding the intraoperative complications, uterine lacerations are one of the common complications which can happen with a Caesarean, and it happens in a lower transverse incision is made for Caesarean in arrest of descent in second stage, or when there's a big baby which is being delivered by a Caesarean and that too in an emergency. Bladder injury can happen during a Caesarean delivery. Minor injury can happen when you do a vigorous bladder retraction. A major injury can happen in repeat Caesareans when the bladder is adherent to the uterus or to the anterior abdominal wall. Ureteral injuries can also happen during a cesarean delivery, and that usually happens when there's an attempt to control bleeding from lateral extensions into the broad ligament. Bowel injury can rarely happen when you're entering the abdomen in a repeat laparotomy for a repeat cesarean section. Uterine atony is also a common complications during a cesarean delivery. Regarding the activation for risk for the massive transfusion protocols, which can happen after cesarean delivery, usually happens when there's an abnormal placentation in the scar. When there's a previous cesarean delivery, the risk is much more higher. When there's a uterine rupture, atonic uterus, and sometimes even in a primary cesarean delivery, the risk for activating a massive transfusion protocol is quite high. And women with abnormal presentations at a previous cesarean will have the highest increased risk for activation of massive transfusion protocols. Infections is also a common complication of cesarean compared to vaginal delivery. Post-cesarean endomyometritis is the most common complication. It occurs due to ascending infection from the cervicovaginal flora because you breach the barrier when you deliver abdominally. If it's not treated adequately, it can lead on to peritonitis, abscess, and septic phlebitis. Wound infections can also happen in 1 to 5% of cesarean sections, and wound dehiscence can also happen. And suppose necrotizing fasciitis happens after a cesarean, it can be life-threatening to the mother. Hematomas are quite common after a cesarean section of bladder flap hematomas, a subfacial hematoma beneath the rectus sheath, angle hematomas if you have not sutured the angles properly. A broad ligament hematoma can happen if there's a uterine laceration and the laceration is extended into the broad ligament vessels. Retroperitoneal hematoma can also happen after cesarean delivery if hemostasis is not achieved after difficult cesarean section. Less than 1% of women with an endomyometritis after cesarean develop septic thrombophlebitis, and the lady who has developed a septic thrombophlebitis may present with a spiking fever with chills, and you have to suspect that there's a septic focus there when she fails to respond to the routine broad spectrum antibiotics which are given, and you're given for almost 5 to 7 days and still there's no response when after treating with antibiotics. And whenever you suspect septic thrombophlebitis and treat the mother, you have to add anticoagulation because there's a high risk of spreading of the thrombus, and it can go on to thrombus of the other vessels and especially the pulmonary system. Venous thromboembolism is a major cause of maternal morbidity and mortality in postpartum mothers. And the risk of venous thromboembolism is elevated during the postpartum period, which is very much more common after cesarean delivery compared to vaginal delivery. Clinical venous thromboembolism was noted in 0.6 per thousand deliveries by elective cesareans, and it's 0.8 per thousand deliveries after an emergency cesarean delivery, according to a study in 2004. According to the Society for Maternal and Fetal Medicine guidelines of 2020, they've recommended that all women who undergo cesarean delivery should receive sequential compression devices starting before surgery, and the compression devices should be used continuously until the patient is fully ambulatory in any patient who undergoes a cesarean delivery. And regarding amniotic fluid embolism, it can occur postnatally and it's more common after instrumental vaginal birth and a cesarean section. And when they identified amniotic fluid embolism after cesarean section, 61% did not even have a labor, but they had gone for an amniotic fluid embolism. And in 81% of mothers who had an emergency cesarean, they had amniotic fluid embolism. So it's much more common after cesarean. It may be elective or emergency, but still amniotic fluid embolism is quite common in these mothers. The neonatal risks due to a cesarean are the breastfeeding complications are much more common because the mother is unable to feed the baby after cesarean because of her pain or if she's under anesthesia and she's not recovered from that. And the baby also got a higher incidence of respiratory distress, which is more common in an elective cesarean group compared with babies which are born after a emergency cesarean. And they also identified a higher risk of hypoglycemia in infants who are born by cesarean group, and the incidence is almost twice as high as infants who are born by vaginal delivery. And according to the Lancet of 2018, there are some short-term risk which has been attributed to the neonate due to a cesarean delivery. And they have said the short-term risks are an altered immune development, an increased likelihood of allergy, atopy, and asthma, and also a reduced intestinal gut microbiome diversity. And babies who are born by cesarean section have got different hormonal, physical, bacterial, and medical exposures, and these can subtly alter the neonatal physiology, according to a study which was done in 2018 by Sandel et al. And that's why you have to think twice before you go for a cesarean delivery. And when you compare planned cesarean section and the neonatal problems, When you perform an early birth before the baby becomes term at 40 weeks, there's an increased risk of respiratory problems and hypoglycemia when cesareans were done electively before 39 weeks of gestation. Severe maternal morbidity which can happen due to cesarean delivery or many, and the first one is the morbidity can be because of hemorrhage, and which can require a hysterectomy or a transfusion. The morbidity which is attributed to cesarean is, it's very rarely uterine rupture, but it can happen. Anesthetic complications are quite common. Shock can happen, and cardiac arrest, acute renal failure, assisted ventilation, venous thromboembolism, major infections, or in-hospital wound disruption and hematoma are all increased threefold of a cesarean delivery as compared to vaginal delivery. It's 2.7% versus 0.9% respectively. So that's why the morbidity is much more after cesarean compared to a vaginal. Maternal mortality can be a surgery-related mortality or anesthesia-related mortality, which is quite rare in a vaginal birth. The long-term risks to the mother because of a cesarean delivery is of an increasing risk of placenta previa in her subsequent pregnancies, the increasing incidence of placenta accreta. Surgical complications are much more common. A uterine wall defect or niche, which has been discovered in lots of patients in the recent decade, is because of increasing cesarean sections. Ectopic pregnancy is increased because of a previous cesarean. Surgical complications are much more, and there are long-term risks to the baby also because of a cesarean. The incidence of placenta previa increases with each subsequent cesarean delivery. It's 1% with one prior delivery to 3% with three or more prior cesarean deliveries. The morbidity also increases with repeated pregnancies, and after 3 cesarean deliveries, the risk of a placenta being complicated by a placenta accreta is nearly 40%, and that's why it becomes dangerous to the mother. The combination of complications also increases the maternal morbidity and also increase the adverse neonatal outcomes such as NICU admissions and perinatal death. And although the initial cesarean deliveries are associated with some increase in morbidity and mortality, the downstream effects are much greater because of the risks from repeated cesareans in future pregnancies. There are chronic complications which can happen due to the scar. And the first is there may be a technical difficulty for performing a pelvic ultrasound in patients who have undergone repeated cesarean deliveries because of the adhesions which can happen between the uterine wall and the abdominal wall. And the Caesarean scar niche is defined as a tethering of the endometrium that can serve as a reservoir for intermenstrual blood and fluid. And these women will have intermenstrual spotting and abnormal uterine bleeding after the cesarean deliveries, even when they have finished the childbearing. And when you put an intrauterine device in a patient who's undergone repeated cesarean deliveries, it can be malpositioned, and there can be problems with the IUCD device which you're putting in. Scar endometriosis is another complication which can happen and that can develop in the abdominal wall years after surgery. And the increased risk of implantation abnormalities includes Caesarean scar, ectopic pregnancy, retained products of conception, and placenta accreta. The Caesarean scar niche is a special complication which happens because of Caesarean section, and there is an association between the number of previous Caesarean and the development of a niche or isthmocele. It's a uterine wall defect that can occur as a result of a Caesarean section scar. The Caesarean scar niche is linked to dysmenorrhea and chronic pelvic pain in the mother later on in her life, and it also has been linked to gynecological procedure complications, poor pregnancy outcomes, and clinical symptoms like postmenstrual spotting and intermenstrual spotting. Ectopic pregnancy is also increased when the mother has got repeated cesarean section, and the increasing rate of Caesarean scar ectopic pregnancy is mirroring the increasing rate of cesarean section. There's a disruption of the endometrium and the myometrium after cesarean delivery, and this predisposes to an improper implantation at the site of the prior hysterectomy. Without a normally surrounding endomyometrium, and untreated Caesarean scar ectopic pregnancies can result in uterine rupture with severe maternal hemorrhage and sometimes even death because the diagnosis can be late. There's also a higher risk of cervical ectopic pregnancies in women who have undergone previous Caesarean sections. Surgical complications happen much higher in patients who have undergone Caesarean section compared to vaginal deliveries. And there's a higher risk of bowel obstruction and incisional hernia, and the risk is almost increased threefold of the Caesarean section groups, with many patients needing redo surgeries. Obesity, smoking, and one or more previous sections are significant risk factors for the development of these surgical complications. And compared to an elective Caesarean section, emergency section will increase the risk of bowel obstruction, insertional hernia much more. And the other long-term complications of cesarean section is the wound dehiscence and the chronic abdominal pain, which happens more after cesarean section compared to vaginal delivery. And there's a median time to diagnose of after cesarean section is 2.9 years for chronic abdominal pain. And the complications are much more in obese women. And in obese women, when they have cesarean sections associated with increased risk of surgical wound complications, can include hematomas, seromas, abscesses, dehiscence, and surgical site infection. And there's also long-term risk to the infant because of cesarean delivery. And there's an association between cesarean section use and the greater incidence of late childhood obesity. Obese children are much more after cesarean delivery compared to a vaginal delivery. And there's also an increased risk of asthma. There are few studies that focus on the effects of cesarean on cognitive and educational outcomes in these neonates in their adulthood. And the guidelines on risk of cesarean deliveries has been brought out by American College in 2023 and NICE guidelines in 2021. And they've said when you want to compare the risks in a vaginal delivery and a cesarean delivery, the overall severe morbidity is 8.6% in a vaginal delivery, whereas it's 9.2% when the mother undergoes a cesarean delivery. The mortality is 0.9% after a vaginal birth, but it's 2.7% after a cesarean delivery. The maternal mortality is 3.6 in 100,000 women, but it's almost 13.3 in 100,000 women when they undergo a cesarean delivery. The risk of amniotic fluid embolism after vaginal delivery is 3.3 to 7.7 per 100,000 women, whereas it's almost 15.8 per 100,000 women. And placental abnormalities do not happen with vaginal deliveries, but it's increased with each cesarean delivery. But the American College did not find any difference in the urinary incontinence and the postpartum depression, which is quite common to both vaginal and cesarean births. The neonatal outcomes, according to the American colleges, when there's vaginal delivery, the lacerations in the baby, they have not found any case of that. But after cesarean delivery, the lacerations which can happen in the neonate is 1 to 2%. The respiratory morbidity is less than 1% when the baby is delivered vaginally, whereas it's 1.1 to 4% increased respiratory morbidity if the baby delivers without labor. Shoulder dystocia is more common in a vaginal birth. It's 1 to 2%, whereas it's 0% in a cesarean delivery. And according to the NICE guidelines of 2021, they compared the outcomes between vaginal birth and cesarean birth. And the outcomes which is more common, commonly associated with cesarean birth is a peripartum hysterectomy. And that is almost 70 more women per 100,000 women who had a cesarean birth would be expected to have a peripartum hysterectomy. And maternal death comparison is 20 more women per 100,000 women who had a cesarean birth would be expected to die compared to a lady who delivers by vaginal route. The length of hospital stay is 1 to 2 days longer on average with a cesarean birth compared to a vaginal birth. About 60 more women per 100,000 women who had a cesarean birth would be expected to have placenta accreta in her future pregnancies compared to a vaginal birth. The risk of uterine rupture in future pregnancy or birth is almost 980 more women per 100,000 women who had a cesarean birth would be expected to have a uterine rupture in her future pregnancies. And the neonatal outcomes according to the NICE guidelines, the neonatal mortality is like almost 20 more babies per 100,000 mothers who delivered with vaginally would be expected to die. Whereas asthma, 310 more children per 100,000 deliveries, those mothers at a cesarean birth would be expected to have asthma in their adolescence and adulthood. Childhood obesity is very much increased with cesarean births compared to vaginal births. It's almost 510 more children per 100,000 deliveries whose mothers at a cesarean birth would be expected to have obesity as they become older. I'd like to thank Dr. Ratnashree, Dr. Suranta, and the Perinatal Society of Sri Lanka for the opportunity. Thank you so much.
We have a few more minutes for questions. Any questions from the audience?
May I ask one question from Chamila? Normally, would you consider like after cesarean section for how many days it is safe to keep before discharging home?
So actually 3 days is more than enough. Most of them recover by that time, and keeping them in the hospital for a longer time may not be an ideal situation because the mother and the baby can acquire infections when they are actually not at risk for such infection. So do not keep them for a long time. We ideally keep them for 3 days. If any other problem is there, we keep them for more days, but not more than that. And ambulate them as quickly as possible. That's the main thing that you can help them to recover.
Okay, thank you.
Thank you, sir.
There's one
And we are following
question.
that enhanced recovery after surgery protocols we follow for cesarean births also. So they recover much faster.
I am Dr. Asoka Veerakodi, retired obstetrician from UK. You quoted from, I think, guidelines 1 to 2% risk of fetal laceration at Caesarean section. I know
Yes,
this is
sir.
quoted everywhere, but in your own personal practice, in our practice, I don't think it's acceptable. Do you think it's acceptable?
No, no, you are not. You can do a very, very safe cesarean for a baby if you can follow all the precautions. Do not use scalpels. I use actually a single blade of the scissor and then open up with fingers. Then you don't cause those lacerations at all, if you're very careful. That's a quote from the guidelines, and I do not accept that.
Thank you very much for your presentation. Given the complications that you mentioned, do you think that as clinicians we put enough emphasis on educating prospective mothers on the complications and the advantages?
Thank you so much for that question, ma'am. I would say we need to counsel our mothers from the pre-conception period, counsel them during the antenatal period also. And the increasing cesarean delivery rate, which they are quoting, is not because of us. We all of us try to follow as much as possible to try to give them a vaginal birth. But when the lifestyle of the mothers have changed and they're not willing to go into labor without when you do a proper counseling, most of them accept. But many are very reluctant to go through that pain process nowadays compared to earlier. So the counseling forms a very, very big part of how you are going to manage these mothers in the intrapartum period as well as the postpartum period. And I think we need to spend more time with them to make sure that it goes through. Otherwise, in the intrapartum period, the clinical process is quite good for every obstetrician who's gone through so much of work in their lifetime. So it's not the part of the obstetrician. I think the counseling part is very, very important, and that you need to spend more time with the mothers before they go into the intrapartum period. It's a very, very important process.
Thank you very much.
Thank you.
Last question, Dr. Shamila. Because
Yes,
Sri
sir.
Lanka, we have the Caesarean section rate is very high, about 35 to 40%. Now, the initiation of breastfeeding is a huge problem, especially after Caesarean section. What advice you give? How do you
Same
overcome
things.
this?
You have to keep your paramedical staff first trained on how to help the mother to feed in the post-cesarean period. They have to be willing to help the mothers because they're more oriented towards the other parts of management of the mother compared to breastfeeding. And that has to be insisted to the paramedical staff. And the counseling in the antenatal period to the patient and her attender will form a big part of helping them to breastfeed in the immediate postpartum period. And in cesareans, there needs to be lots of motivation from the mother, because with her pain, she'll find it very difficult to feed the baby up to the optimum. So for that, lots of help are needed in the first 1 to 2 days. And once it's set, most of them do quite well. But when we are not taking that care and precaution to help them out, it doesn't happen so often. And many complain during the second pregnancies also that the first pregnancy, they were not comfortable with breastfeeding.
Thank you, Dr. Shamila. So we'll close this session. Thank you very much for
Thank you,
your
sir.
very interesting lecture. So we'll move to the next topic, that is on prevention of burden of the primary Caesarean section. Our speaker is Dr. Chandana Jayasundara. Chandana is a consultant obstetrician and gynecologist, service of maternity hospital, and senior lecturer in obstetrics and gynecology, faculty of medicine, University of Colombo. He has fellowship in gyne-laparoscopy and certificate on fertility. And he is the general secretary of SLCOG, and he is the secretary of Endometriosis and Endometric Society of Sri Lanka. Special interest on minimal invasive surgery, endometriosis, subfertility, and labor ward care. It's over to you, Chandana.
Thank you. I would be talking about the burden of primary cesarean section. So, with the current topic about the burden of cesarean section, preventing the primary cesarean section carries a huge impact. So, I think it's a very timely lecture. And so we all know that the current the trend in global situation is that the cesarean sections are increasing worldwide. It's ranging from 5% to 42% in some parts of the world, nearly 50%. That means, but it is actually rising in all the regions in the world. So if you take this graph, it might be not very clear, but we can see they have predicted in all parts of the world that by 2020, we would be reaching 50% if we not curb this trend. So most of the stress is now to see whether we are doing the caesarean sections which are indicated, or if not, how to reduce them. So what had happened to the local scenario? Well, in Sri Lanka, the caesarean section rate has climbed from 9% in 1986 to 39% in 2018. And in a study that was quoted in our unit, it was 33.2% in 2015. So what we can see is there's a wide heterogeneity. A lot of reasons are behind that. But actually we are averaging 35%, as our chairpersons was telling just a few minutes back. So what are the trends for this? What are the reasons for this rising trend? Well, it's multitude of reasons. But mainly, it is about increasing the primary caesarean section rate, which will contribute invariably to increase the repeat caesarean section rates. So other thing is actually increased use of intrapartum fetal monitoring without it should be increasing the, it should reduce the need, but then again what happens is without proper training and proper additional monitoring facilities, it might actually increase the caesarean section rate. Then failure to progress after induction of labor, which we have not done if we are not done the induction process properly. Changes in the obstetric training has had a huge impact, and the medical legal concerns are there. So the obstetrician might be worried if the non-reassuring CTGs, or if we don't have further facilities, it might cause trouble. So they might render doing a caesarean section. And as we told, social expectations of pregnancy outcome and the maternal autonomy of decision making. So tocophobia takes a huge place in this. There are so much of research done on that area as well. Proper pain relief in labor, these things has to be come in place. What is the impact of this increased trend? Well, caesarean section carried out without medical reasons have a significant morbidity and mortality in maternal as well as fetal morbidity. We all know in the next lecture, Dr. Ratnasiri will be talking widely about the problems with placentation and the repeat scar and these issues. We all know about high risk of major additions. Even we experienced last week a major problem in that with severe bowel additions, and she is still in the ICU, and high risk of postpartum hemorrhage as well. And we all know even the child who's born by a caesarean section has higher chance of respiratory tract infections, risk of obesity and asthma in early childhood and late in life. So these issues, and we must not forget the additional healthcare costs that a country like who's trying to get up from recession would be, how much a burden it will affect on the health system. So why this primary caesarean section matters is the issue. Why am I talking about primary caesarean section rather than a whole? Well, if you have a previous caesarean section, it's increasingly important determinant on overall caesarean section rate, because we all know once a scarred uterus, everybody is frightened to allow a vaginal delivery. Even yesterday we had the workshop and we were talking with Professor Michael Robson, and he was telling the biggest problem is he would not induce even past caesarean section. So it has multitudes of opinions, but people are not happy to dabble with a scarred uterus. So invariably, if the primary caesarean section rate increases, the whole caesarean section rate will have a huge impact on that. Will have a huge impact on the local caesarean section rate. So what has happened in the global and the local area? So you can see nulliparous women and multiparous women. I have quoted several two studies here. So we are increasing. So we have nearly 50% in nulliparous, and multiparous also it's high. And you can see that in the local setup, we are even higher than the global setup. So actually speaking, we have a higher rate of primary cesarean section rates. So the reasons, what are the reasons for increase in primary cesarean section rate? Well, causes are varying, and we have to always think about the clinical situation. We cannot give a blanket solution or a blanket cause for this. So several studies have quoted several issues. We have also done studies about this. In one study, they were thinking about overuse of labor induction, modifiable indications like malposition, litigation fears, and on-demand cesarean section carries a risk. But in Sri Lankan study, they have found out primary mainly due to fetal distress and primary subfertility as main contributors. And in our study, we also found induction of labor and medical complications coming as a primary source of increase in primary cesarean section. So how can we reduce it then? Well, strategies to reduce cesarean section, primary cesarean section, while maintaining a safe outcome for the mother as well as the baby, well, we have mainly 3 areas to concentrate. One thing is continuously auditing the primary cesarean section rate and the underlying causes, implementing effective strategies to optimize these rates. I'm not telling to reduce in the sense cold term, you have to optimize it. Then improve the, once you, to implement these effective strategies, we have to implement clinical guidelines and quality of care improvements to patients. So for this purpose, in 2015, the WHO and 2016, the FIGO proposed the use of this Robson's classification as a global standard for assessing, monitoring, and then comparing cesarean section rates over healthcare facilities, over time, and between healthcare facilities. So this has 10 categories, and it has basically 6 main components that you have to fill, and then you can divide these women into exclusively different categories for their labor process, for their outcome process in labor. So this is basically, I won't spend time because I don't have much time. So this is the WHO, the book, picture taken from that about the Robson's 10 group. So with using this, it has been proven that it can actually, we get the awareness about the cesarean section rate, and we can implement strategies to reduce it. So there are several studies that I have quoted here, and it is known that about auditing and re-auditing and then implementing guidelines, we can come above the burden. So there are several studies done, using this classification in, but they were not sustainable on the long run. We had a workshop yesterday as well, and we came across many studies that were done here, but they are all ad hoc studies where they would use a time period. So most of these studies were done using paper-based recording systems, and we don't have in Sri Lanka electronic data recording systems in place, and we don't have secretaries to handle this data. So most of this data is not practical in our situation. So if we go into the main problems in Sri Lanka about this, using this classification system, is we don't have institutional structure related issues, and we have shortage of staff, we have financial issues, we have limited resources, and we have limited access or unavailability of electronic databases. So how can we implement this, and how can we try to understand the situation and curb our cesarean section? Well, we proposed for this, we did in our university, we proposed using a smartphone-based app, and we designed this using BOYD principle, that is bring your own device principle. So you don't have to use computers for this, your smartphone will do it for you. And it has only 1 page, and it takes only about 2 minutes to enter this data. And we have published this in our journal, and it will be out this month. So this is a front page of the data. I mean, it's not clear, I think, for you, but you can go into the website and you can get it. It's a web app, so it's very easy to download. It takes only about 2 minutes. So ultimately, in the the second slide, you can see it will give you all the rates, and the number of women in that group, all these things. And then not only that, it will use a little bit of AI, and it will tell if the rate is higher, why is it high, and what can you do to curb it. So that is with the WHO guidelines. So we have done 2 studies with this. One was done in our hospital, and the other one was done as a multi-center study. In our hospital, in Disoesa Hospital for Women, we did a study of 1,712 women using this app to see whether it works. And it will be published in the near future. And then we went on to do a multi-center study, collaborating with Mahamodara, Rajarata, Ragama, and Peradeniya, the major hospitals, to see the heterogeneity of this primary cesarean section rates, and to analyze what are the reasons behind that. Well, you can see, if you see this graph, this is our hospital study, and we try to compare it with the multi-center, multi-country survey study, and a study which was done in the same unit some time back in 2017. So the blue line is the WHO recommendation. The orange line would be a study which was done in 2017, and the ash line would be our study. Now you can see groups 1, 2, 3, and 4 are primary cesarean section rates. Group 1, 2, 3, and 4. That's the first 4 lines. So you can see everywhere that we are having a rising trend except for the group 1. Group 1 is primary cesarean section rate in spontaneous onset of labor, but other than that, other areas we are increasing. So it's an area that we have to be looking at. So even our trend is increasing. These 4 groups, and in most of these, it is more than the recommended level as well. And if we take the comparison of the cesarean section rates, you can see group 1 and 2 is nulliparous women having a cesarean section rate, and that is the highest. So we have to look into this very seriously. So there's nothing much we can do after group 4, that is past sections, and all the other things, anyway they are going to have a cesarean section. Group 1 to 4 has to be concentrated, and the guidelines has to be targeted to reduce these sections. And if you see this in different hospitals, major hospitals in Sri Lanka, the induced labors having cesarean sections, these orange lines, are skyrocketing. So it's a huge burden everywhere. It's not only in our unit, it's everywhere, all over the country. So this needs the college and the Perinatal Society, everybody's input has to be taken into account here. So, the problem is identified, solutions has to be implemented. I gave some propositions, but the problem is still there at our hands. So what are the strategies that I propose at this moment to reduce this rising trend of cesarean section in South Asian units? Well, to introduce new labor care guide. So we talked about this in our college sessions, and it is going, the college representative and the family health bureau representative also told that it is going to come in very soon. So I think it's going to be a major impact in reducing the cesarean section rate. So introduce the new labor care guide, the WHO recommended guide, and improve fetal monitoring facilities in labor wards. This has to be coming with a lot of infrastructure and financial input. And also involvement of senior people in decision making regarding emergency cesarean section. So we were thinking about this. We actually thought of developing another electronic method of communicating. If you can upload the partogram, the CTG, and the basic decision-making process, rather than over a phone telling, okay, there is a fetal distress, shall we go and do a cesarean? Rather than that, if we can have an electronic platform where the consultant, if even not be able to present in person in the labor room, which is not a possibility at this moment with the facilities we are having, it might have a huge impact. And I think that's a take-home message for us. We are thinking of that. And avoid unnecessary inductions of labor. It's very, yesterday it came out the point that maybe we are, even if we are thinking that's a high risk and we might have to deliver, we might think we might be inducing even for a small chance of inducing. That ultimately that woman will undergo an induction as well as a cesarean. So that was pointed out by Professor Robson yesterday. We might be inducing even with a half a chance or half-heartedly. So that might be the cause that we are having so bad cesarean section rate in South Asian countries, unlike in Western countries for induction of labor. And use of apps like what we have developed to audit and to compare cesarean section rates in induction of labor women and other women who are undergoing cesarean sections, and to use this data in a continuous manner to develop new guidelines and to provide standards of care in individual units rather than giving a whole value for the whole country, because these things change with each and every unit. Thank you.
We can take some questions from Chandana.
No, thank you very much, Chandana, bringing forward this topic. And as you said, we are facing this big problem of how to bring down cesarean section rate. However much care pathways that we produce, those care pathways, if they are not being practiced in the hospitals, then the use of it is questionable. So one problem we encounter is there are guidelines, and now we have go beyond guidelines. Now it is clinical care pathways, which are not available here in Sri Lanka. Though we produce them, practically they are not being implemented in the labor ward, in the hospitals. So there is no standardized care in our hospitals. It depends with the consultant who heads the units. So that is one problem. The second problem is the structure, the structure of obstetric care, which is delivered in the hospitals. So in our setup, don't you think the labor ward is a little isolated? So the consultants who visits labor ward once or twice a day, and then the labor ward is being managed by SHOs and HOs. So the decisions are taken by over the phone. So the consultant decides from the information that he gathers from the HO or SHO, who gives the information from the labor ward. So sometimes the SHOs manipulate the consultants if they want to end the shift and go home, and they give the story to the consultant so that the consultant would get the answer from the consultant, what the answer that he wants. So this has been practiced. The consultant is reluctant to go to the labor ward because he's also busy. So and I think we are high time we have to go to a setup where it's not individual units. It has to be a unit manned by several consultants, and the labor ward has to be manned right through 24 hours by a consultant. So consultant has to give his input to the labor ward when when a decision is taken to do an emergency cesarean section. Because a lot of CTG changes we can tackle with the intrauterine resuscitation of the fetus, which is not being done mostly in this country. So whatever we discuss here and whatever the care pathways that we are going to produce in future, if the structure of the labor unit is going to be the same and the one-man stations is going to be the same in this country, do you think we can ever bring down this cesarean section rate?
Yeah. So that's very good, excellent points that I think I stressed out those things in my lecture as well. So, number one point you were telling was about the labor board, the SHOs trying to manipulate, or it's not the SHOs, anybody, maybe the registrar even can do it. So they might, at 4 o'clock, time is up, we have induced at 5 o'clock. So it might be, she might be just entering the active phase of first stage of labor, and we just go and do a Caesar because we are worried about it. And that can happen. So how are we going to change that? Now, you were proposing about a labor board lead or labor board consultant. But I mean, according to information, I have not gone to UK. I have been practicing it. I mean, I was trained in Australia. So this labor board lead thing really came in UK, if I'm correct. Australia, we didn't practice anything like that. There was a whole consultant who was on call for the whole board. But I think it's not successful there as well, because it's very difficult to find that much of consultants at this moment. So that's why I proposed, at least, we developed an app for that actually in our unit. So to upload, and just the consultants will, once they get the call, they will have to decide on the record that they have got. And this will be recorded. And this will be recorded and it can be audited in the end. But the problem was the facilities again, because nowadays we cannot use it for Apple smartphones because they charge a lot of money. So you can't introduce an app like that. But Android, yes. But the problem is most of the registrars, and they will say, we have Android, Apple, so we can't be using that. So we had to buy a separate tablet or a phone for each and every labor board. Then we can use this way, and it can be audited, and it will be recorded all the time. If the registrar says over the phone and take a decision without sending the partogram and the CTG and the progression up to now, it can be taken up in the audit at the end of the clinical month. But then comes the issue of what you were telling. Then best thing is to have single, rather than each consultant having a labor board for himself, which actually, if we have a whole labor board, we can actually fund all can get together and fund maybe a smartphone. They can communicate, and everybody will be using the same labor board. So that is actually should be the way forward, I also think. Actually, we proposed this in the Family Health Bureau meeting, that they are now carrying on to propose to develop new labor boards. And I think the only problem is, again, there is resistance from consultants, and some are asking that they want a separate unit, and they don't want. I mean, we can imagine forget about Caesarean section rate, the economic burden it's giving to the country. When we were in Australia, there was only one registrar and one consultant, and to the responsible for the whole hospital, that is 5 wards like. But in Sri Lanka, there are 5 wards, we are running 5 labor rooms, 5 consultants are on call, 5 registrars, 5 senior registrars, and the SHOs all are on call. So we are having enormous burden in economic wise also as well. That's my personal wish, and I put forward this in the meeting as well. So I hope these things has to be changed. You are right, but let's have fingers crossed.
Thank you, Chandra. So one of the things we can do is to improve reduce the Caesarean is to implement the WHO care guideline, the new one, and probably will come into effect soon. Other thing is improve the fetal monitoring. Can you just elaborate on what we can do to improve the fetal monitoring?
Yeah, so what we can do is, now in all our staff has to be trained in interpreting fetal monitoring in labor. We have thought about this as well in our unit in Colombo. So we have introduced, my friend, he will be talking tomorrow, I think, Mohammed Rishad. He has developed a program that can be done through internet, and it will be introduced this year as a short course in certificate course to master the CTG knowledge in their unit. So they can have a certificate and they can do it each year. And it is a computer-based system. You can go to the net and you can get yourself accredited. So that can be done as a one-time thing, but if it is to be really successful, you have to, every newcomer has to do it, and every year you have to do it, so that you will be refreshed with your knowledge in CTG. This course, I think, will revolutionize that if it is uptaken by the ministry. It's a very good course. It is validated and it will be introduced very soon in the net. So that thing, and just the auditing process. We have to audit our data. If we don't, we will not find what is happening. So auditing is also extremely important, and updating our knowledge in areas we are lacking is extremely important.
Okay, thank you, Chandana, for that excellent presentation. So the last session of this is to be presented by Dr. UDP Ratnasiri on why the fear of scar. Dr. Ratnasiri doesn't need introduction, but it's my duty to read his short CV. He's a consultant obstetrician and gynecologist at Castle Street Hospital for Women, and the past president of Sri Lanka College of Obstetricians and Gynecologists, past president of the Perinatal Society of Sri Lanka, treasurer of the SAFOG, chairperson of the Maternal and Fetal Medicine Committee of the AOFOG, and the chairperson of the International Representative Committee of the Royal College of Obstetricians and Gynecologists. Over to Dr. Ratnasiri.
Thank you very much. Good morning, all of you. I think my talk is mainly on the VBAC and the fear of scar rupture. So this is not to reduce the Caesarean section rates, and this is to see how we can give a trial of scar, but it is not always without a risk. And we have an over fear of the scar rupture, which is shown in the picture that is shown there on the, so somebody has created a fear, but still it's a fear. So you know, scarred uterus belongs to mostly the group 5 of the Robson classification, so it has only limited numbers of patients in our setup, but it's not the Caesarean section rates. When you do repeated Caesareans, the consequences that we see, the placenta accreta spectrum of disorders. So that is a worry more than reducing the number of Caesarean with this. So with that in mind, so VBAC and the fear of scar rupture. Now, when you go to the history in 1916, this was published in Conservatism in Obstetrics in Eastern Medical Society of New York. The Craiggin, it's a dictum, once a Caesarean, always a Caesarean. So when you see the repeat or emergency Caesarean, this is the single indicator for all these. More than 50% of patients with previous Caesarean sections are delivered with repeat elective Caesarean section. This is in the RCOG 2016. You have heard this gentleman named Monrocker. He has published a book on gynecology or gynecology and obstetrician. So he introduced the lower segment Caesarean scar for the Caesarean. In the past, it had been upper segment Caesarean, and always it has to be a repeat Caesarean. So he introduced this in 1926 and demonstrated lower risk of uterine rupture compared to the classical incision. And later on, with the improvement of antibiotics, blood transfusions, anesthesia, and the cleanliness and the hygiene and the safety of Caesarean, this has led to reductions in maternal mortality and morbidity traditionally associated with Caesarean section due to sepsis and hemorrhage. So with that, there was a surge in Caesarean section rate, because in the past we have heard once a Caesarean is done, woman is kept in the bottom, in the lower floor. If she recovers, only she goes back to the upper floor, because some of them die with sepsis, hemorrhage, and the consequences. But with this, the Caesarean had become a safe method. So I think previous speakers spoke about the rising trends in cesarean sections. So globally it is increasing, and we are also in the high rates in the regions. And at the moment it says 1 in 3 women will deliver by cesarean section, but now 1 in 2 will be in the cesarean section if we are going at a rate that we see at present, mostly in Sri Lanka. So I think previous speakers mentioned about the morbidity with cesarean sections. All these are there, but when you see the complications on the right-hand side, the uterine rupture is 2 to 7%, 2 per 7 per 1,000. But when you have a scar with the placenta previa, it is increased than that 4 to 8 per 1,000. So that is a worry that we have. And if you are going at highest rate of cesarean section rates, we have to face this situation and management without much of morbidity and mortality. So we have to be geared. So this is what I mentioned. So when you consider the risk factors for placenta accreta spectrum disorders, cesarean section carries 0.3% with 1 cesarean to 6.74 with 5 or more. Now at the moment I have a patient in my ward with the 4 cesarean sections with the placenta accreta spectrum with the bad hemorrhage she has had. So we have to face this situation if we are doing repeated cesareans. Now Chandana mentioned about the primary cesarean. So what I am mentioning is if we can give lesser number of repeated cesarean sections, you can see the risk of the placenta accreta when it is 1, 2, 3, 4, 5, and 67%. So half of them if they have a placenta previa on top of a scarred lower segment. So these are concerns, I think, previous speakers. So we have to see how we can reduce the cesarean as well as improve our trials with safety. So again, when we go back to the past, Eastman in 1950 stated preference for a vaginal delivery after a cesarean, and he has achieved 30% at Johns Hopkins Hospital, but they had a mortality rate of 10% and 2% of rupture rates. In 1969, again, they have seen overall cesarean delivery rate after cesarean has come down to 5%. So when you see the advantages of a vaginal birth after cesarean, it's true that pain is there for the labor. So if you can give adequate pain relief with multimodal analgesia, if it is available, that will reduce the pain, but it is less painful after post-op vaginal delivery. It avoids major abdominal surgeries. Nowadays, a cesarean and the uterine remodeling is the concept that we follow with the subsequent complications we are achieving. So if you read the latest article in American Journal, it mentions uterine remodeling after a cesarean. It has all the complications and how it comes, and mainly the adhesions with the repeated cesarean section, not only the placenta accreta, and the difficulties and the other consequences with and early mobilization, less risk for VT, that is thromboembolism, I think previous speakers, and reduced hospital space, and quick return to normal activities. It has more bonding with the baby, and early feeding and care is started, and less respiratory problems with the baby, and higher chance of future successful vaginal delivery. If you give a VBAC once, there's another chance for VBAC. So when you see the trends of VBAC over the decades globally, I don't have latest data, but you can see total cesarean section rates have gone up, and with that primary cesarean section rates also coming up below parallelly. And VBACs have come down. There's a concerning decline in the VBAC rates in the last decade. So that is seen globally, not only in our country. So there are fears, there are several reasons, and it's sometimes accepted to do a repeat cesarean section if the supportive care and your emergency situations are not geared to do an emergency repeat cesarean section. So these are in different countries scenarios from different areas. So some are having higher VBACs. This is sometimes back. These again, United States, Australia, Canada, United Kingdom, and Sweden, Netherlands rates sometimes back in 2015. So VBAC rates have gone down over the years with the fear. It is fear of scar rupture, but these are the main fear that all of us have. So before rupture, if you catch, we can prevent the rupture, but still it is sometimes a difficulty because whatever measures we have to detect this may not be always reliable, especially when you are monitoring. If the monitoring is poor, if the supportive care is poor, the difficulties detecting is there. So if you see these charts, the first chart I have shown, so number of deliveries in different years, 80 to 83, it has gone down, but the rates of VBACs have gone down in the same rate on the other side. So why VBAC rates are falling? The fear of scar rupture. Now this is obtained from a book from American ACOG. So spontaneous rupture of unscarred uterus is very low. There is no risk at all, like very remote risk. When it is a previous transverse cesarean, not undergoing TOLAC, there is no very much risk. Because sometimes we see when you do the repeat elective Caesarean sections also there are some gaps and gaping seen. So that this doesn't mean that always a labor, without labor also you can see some silent ruptures, may not be complete but partial ruptures, only the peritoneum is intact and the myometrium is gone. When it is a previous transverse section undergoing spontaneous onset of labor, there are different rates available, 0.45 to 0.72. So 3 to 4 relative risk compared to the elective repeat Caesarean section. So that is seen in the upper one. So there is a risk 3 to 4 times compared to the repeat elective Caesarean. And when you use oxytocin for induction of labor in previous Caesarean section, it is much more, 1.4 versus 0.3 in the previous one. So there is a little higher risk compared to, not little more higher risk compared to the spontaneous. So no difference related to oxytocin in one, but judicious use of oxytocin is the main thing. So I use oxytocin, but it's mainly with the consultant's supervision with the team alert on the scar rupture. So when it is previous transverse section undergoing induction of labor with prostaglandins, again similar risk, but it is on the higher side, like oxytocin 1.4. Now sometimes we have seen prostaglandin is used for the favorability of making the cervix favorable, and oxytocin is used on top of that. So that is the worst situation where hyperstimulation and risk of scar rupture is seen. So more than one previous Caesarean section, anyway, you all know the rupture is there, risk of their classical Caesarean section. I said that it had been in the past, and now most repeat section. Previous low vertical also someone, but we consider when it is a Caesarean low transverse scar, whether it is a typical scar or an atypical scar, to consider a Caesarean. Typical scar is a low transverse, but when it is torn, maybe J-shaped, maybe torn down, when sometimes inverted T, sometimes torn on both angles, so those are atypical scars, and others other than low transverse are also considered atypical scars, so risk of scar rupture is high. So before deciding on a trial, I decide whether it is a typical transverse scar with previous nodes, but unfortunately we always don't have the previous nodes, and sometimes they are not mentioned, so those are the ones we have problems. So what are the other reasons for falling VBACs in rates? We can see in this VBACs, it goes to higher risk when it is an emergency repeat section for failed VBAC. So that is sometimes more traumatic than a cesarean which is done electively repeatedly. So the risk goes from low side to high side when it fails and going to do a repeated cesarean section, especially late in the first stage or in the second stage of labor. You can understand thinned out, sometimes difficult scars with adhesions, a repeat elective emergency cesarean section. So that is also another fear, that not only the rupture, the fears, right. Sometimes when you need to do emergency cesarean section for a trial, if the theatre table is not available for a category 1 cesarean section, that is also a trouble for our setup. Now, most of our hospitals have 2-3 tables in obstetrics, but in the periphery, sometimes you have to share with the consultant, other consultants who are doing surgeries like surgeons and the other specialties. So you may not have a theatre in time. So that fear also is there in addition to the rupture fear. So the ultimate rupture is the outcome if you delay it. So we had this kind of situations during the COVID time, maybe the preparation, maybe the delay in anesthetizing, all these are happening during COVID time. I had bad experience, so I decided not to give trials during the COVID crisis period. And when you see the fetal ones, it says antepartum stillbirth, elective repeat cesarean 0.21, and TOLAC it is less, but intrapartum stillbirths rates are higher compared to the elective repeat cesarean section rates with the TOLAC. And HIE, hypoxemic encephalopathy, rates also to be seen higher with the TOLACs. And perinatal mortality compared, I think yesterday we were worried not only the neonatal, but the perinatal mortality again goes to a little higher rates with the TOLAC, that is trial of scars. Neonatal mortality again higher, NICU admissions and the respiratory morbidity is high, but transient tachypnea of newborn is higher with the repeat elective cesarean. So those are also fears. If you are really aware of these fears, repeat trial fear. So again, I'm showing the same more concern on perinatal as well as the maternal morbidity and mortality. So those are the real fears with the repeat with the trial of scars. If you go to the Cochrane trials, so to see the evidence with trials and the repeat elective, it says we looked for randomized trials that compared the outcomes in mothers and babies when an elective repeat section was planned, when an induction of labor was planned. We found no trials on this type. Not many trials had been found to assess which is best method of delivery in trials. So it varies. There is a variation in the practice. And also, in addition to those data, limited experience and knowledge in monitoring the patients undergoing TOLAC. That is sometimes availability of monitoring and the limited experience. Lack of confidence due to uncertainty, lack of good quality evidence. I mentioned no randomized control tried, and trials and heterogeneity of studies. And if you have had a bad experience, again, you feel, why should I try another trial? So that counts a lot. And also when the grassroots level, that is the midwifery level and the bottom people at the periphery, make them anxious about the trial, very difficult to counsel them and get to a trial. And improper counseling is another issue. And patients request for repeat elective section with their knowledge and sometimes with the search with the internet. Fear of changing the practice, sometimes the leadership, it is also. And the worst one is the fear of litigation. If there's a rupture or a maternal death, hemorrhage, hysterectomy, neonatal outcome, those are another. As I mentioned, unavailability of facilities and the staff for a category 1 or a quick cesarean section, that also found. And not following usual practice of interpartum monitoring and respectful labor care. Lack of motivation, poor attitudes of staff, and glorification of cesarean, too post to push. I think cesarean, mostly in the private sector, is glorified. That is the better matter of delivery. And there are other issues, more than the social and other issues, increased trends of obesity, diabetes, macrosomia, multiple. When it is a past section, mostly the trials may not be very easily conducted when it is needed to deliver with the maybe before 40 weeks, the favorability of cervix. And we know the success rates of vaginal birth after cesarean section is higher with spontaneous. If the patient coming from home in labor, she has higher rates. When they are staying in the ward with the past dates, and when you try to get the cervix favorable and induce, or sometimes the rates are falling. That is what I mentioned. Use of prostaglandin and metoprolol may be associated with higher risk of uterine rupture. I mentioned the risk of hyperstimulation and the uterine rupture. If you have controlled release of this, may be useful, but still it is not very advisable. In case of, in these cases, chances for induction with oxytocin is higher. Compared to spontaneous onset of labor, success of VBAC, successful vaginal delivery, is low with induction of labor. Some of these patients with past cesarean section may need early delivery for other medical or fetal reasons. So that is also another. So my experience in Casa Street Hospital in the past years, 2016 to that is 2 years, we had a success rate of VBACs 80.9%. That is the number of 317%. Out of that, 72.6% vaginal delivered, but we had to do assisted deliveries like forceps 4 and vacuum 4.3 and repeat elective cesarean failing VBACs, failing trials 18.8%. So that was during those 2 years 80% success, but when you had this 80% success, so this is the mean gestational age among all these babies delivered during that period, 3 kilos average, and we had 2 ruptures, counting to 0.6%, and in one of those ruptures, the baby was saved because quickly we could go do the cesarean. One of them, baby was saved, but with asphyxia, so there were no maternal deaths, and we had 9 PPHs needing more care compared to the normal management of postpartum hemorrhage, massive PPH. So in all these trials, we have used oxytocin in 63.4% cases and without oxytocin 36.6% cases. So this was the results of those 2 years which I had in my own unit at Casa Street. So between 2018, I could not get detailed, but we have conducted 477 trials. Out of them, we had 367 vaginal deliveries, which is coming to 70.8%. And out of those vaginal deliveries, vacuums 53 and forceps 21. And we had 6 uterine ruptures. Out of these 6 ruptures, 3 happened during the COVID crisis period due to the unavailability, and some of them came in labor. We didn't plan many trials, but unfortunately we had to do repeat emergency cesarean sections, but theaters were not ready. 2 of them were COVID positive patients, and there were delays in anesthesia, and we lost 1 or 2 babies, but we saved another baby with emergency cesarean. So these are the detailed data during that period, 2018. We had vaginal delivery 68%, forceps 5, vacuum 9, and repeat elective emergency cesarean section 18. And it varies. 2019 was the year we had COVID crisis. You can see more emergency repeat cesarean sections failing trials. And 21, again 22, we are better off. More than 70% we could deliver vaginally without much of distance. So what are the reasons for bad outcome in trials? Improper case selection. Pre-labor assessment has to be done by a experienced person knowing the previous scar as well as the other problems with the macrosomia, placental sites, SLI, presentation, everything is counting. Inexperience monitoring and interparty management, failure to recognize complications. Hyperstimulation is the main killer, and not intervening when necessary. So it was not going to the right direction when there is an emergency. So how to overcome these challenges? Overcoming the fear for the change. Now I have experience over more than 35 years as an obstetrician. So from the beginning, from the learning time, from my consultants, I had the experience with the trials. So I was carrying this experience, but time to time it changes, but still I am carrying until the last few months of my career in the government sector. Knowledge to counsel patients correctly, application of standard consent criteria, staff training, middle grade and junior medical and midwifery staff, proper case selection, decision made by the consultants, skills in labor management for high-risk pregnancies, senior level involvement in decision making during labor, timely intervention and risk mitigation, formulation of guidelines and care pathways, and regular audit of the practice. So what are the factors considered? Patient-centered decision making. Discussion should begin early in the course of prenatal care and may even begin before conception. Ongoing discussion throughout pregnancy is important as conditions may arise that alter balance of risks and benefits of planned route of birth. Whenever possible, clinicians should comply with patient's preference also. And availability of TOLAC at the planned birth setting, probability of the birth VBACs, benefits and significance of estimated frequency of complications with TOLAC and repeat cesarean births, and personal values, preferences, and past birthing experience and future pregnancy plans, all these are counted when you consider. So how to intervene in order to overcome the challenges? So all these should be considered, and there's a prediction model which was published sometimes back with RCOG with the standard calculator with fair number of inputs, and that will give the chances for a VBAC and see. So, but with that, there is no proven benefit of improved patient's outcome with this use. It had been seen. So thank you very much for listening. I hope that you have more questions. So it is not always possible. You have to have a solid team with solid backup facilities for a trial. I personally feel we can do, but with care, to avoid repeat cesarean section. This may not reduce the total section rates because group 5 comes to a lower level, but still we can prevent this repeat cesareans and the placenta accreta spectrum of disorders, which is the fear of our setup.
Thank you, Dr. Ratnasiri, for that comprehensive lecture on cesarean scar. The topic is open for discussion. We have a few more minutes.
Thank you very much for sharing your experience. How do you, what is your experience with regard to the previous cesarean women who have had their previous cesarean section for poor progress?
Yes. The poor progress, I may consider it's in the past. The poor progress may be due to several reasons. Maybe inadequate use of oxytocin, inadequate stimulation, maybe macrosomia, maybe cephalopelvic disproportion, several reasons. But I consider the present pregnancy and if it is poor progression in labor, I stimulate with oxytocin and some of them overcome. Even when it is a CPD, the indication for the past, I consider the present size of the baby and consider differently, not considering the past experience. But if they had the previous scar rupture, is contraindication for a trial. If it is a bad total, atypical scar with the tears, we don't consider. But it is the present pregnancy mostly. But when they had a bad experience with the past vaginal delivery, the chances of getting their woman's consent is little difficult for a trial. So we have to consider their preference also. So it's a relative thing. It's not an absolute decision making for a trial. It's relative, I feel. present pregnancy, past experience, preference, everything has to be counted. So we never had bad ruptures and hysterectomies and like what we have in our placenta accreta bloody surgeries. It's a rupture taken, quickly done, sometimes repair then and there, or sometimes in COVID time I said it was a different experience. That 2 years our data was upside down. It is a relative thing. Individual patient has to be considered individually, not as a total TOLAC group. So some of them had, I have not included my repeat elective cesareans here. It is only the trials who were considered for trials, this data.
Yeah.
Thank you very much for the lecture, sir. My question is, how long you will wait until those patients with previous caesarean sections for the spontaneous onset of labor, or what is the induction protocol that you use at your
Yes, thank you very much. Now, if there is no medical indication to deliver early for fetal or maternal reasons, we allow 41 weeks. That is the normal routine. If there is no indication to deliver early, I mentioned that. And if it is reaching 41 weeks, if they are not going into labor, we give the cervical preparations for favorability. Unless they are very favorable, we don't do induction. So we have to make it very favorable in the sense, Bishop score 8, 7, 8. With difficult Bishop scores, I won't try with oxytocin and ARM. So there are a few issues. Now we do the ballooning. We can't use prostaglandin. We use ASOMs and AMMs. I have used double balloons, which though it says it has no advantage, but I have seen double balloon catheters used for cervical favorability had made good favorability with difficult cervices. That is only selectively used. So the normal time period given 41 weeks, my registrars are here, they know what my policy is, but when it is 40 weeks, we assess the cervix and see whether we can reach that period with waiting for spontaneous. If not, we try to make it favorable. And oxytocin is given judiciously with monitoring the contractions. We avoid hyperstimulation. So prostaglandins are not being used as we don't have slow release prostaglandin. Misoprostol also we don't use. You saw the risk of rupture. So we have to be legally protected also when you are using these measures. All according to the protocols, monitoring, everything has to be perfect. So in Casa Street, my team is geared because when I came to Casa Street Hospital in 2014, October, there were 38 patients waiting for repeat elective cesareans. All of them, I made them to go into labor and delivered. So my staff thought this will be a bloody mess here. The butcher has come to this hospital, not the VOG, to give trials and showed them how we can do this without fear. And they are now used to that and they don't have any fear. So it has to be shown with the training, skills and developments and everything. So 38 patients went into vaginal deliveries and succeeded. So it has to be the leadership as well as the training skill and the strength of the team.
Thank you, Dr. Arsiri, for that very interesting lecture.
Thank you very much.
I think we are behind schedule, so we'll conclude this session. Let me thank all three speakers, Dr. Chamila from India and Dr. Chandra Jayasundara and Dr. Yurbi Radhasiri for their presentations.
Thank you, sir. Yes, indeed, we have reached the end of the first symposium titled Managing Past Caesarean Sections to Optimize Perinatal Outcomes. I would now like to invite the chairs of this morning's symposia, Professor Rukshan Fernandopulle and Dr. Mangala Dissanayaka, to present the certificates of appreciation to our speakers. For this, I would like to invite Dr. Chandana Jayasundara and Dr. UDP Ratnasiri. Thank you, sirs. With that, we have concluded the first symposia for this day. We will commence the Professor Indraji Amarasinghe oration of the Perinatal Society of Sri Lanka shortly. So please remain in your seats.